Good afternoon, everyone. So I'm going to call everyone back and we'll get the afternoon's proceedings underway. Just before we resume, we wanted to draw your attention to this study that's projected on the screen here. Nasal suctioning therapy among infants with bronchiolitis discharged home from the emergency department, an RCT. This was a PSI-funded study, and as you can see, it's just been published. I think it actually came out today in JAMA Open Network, so a very prestigious publication. Just to let you know that PSI-funded research is certainly being published in high-impact journals, so some comment on whether that's impactful this morning, but certainly high-impact journal. By the way, this application, when it came to the grants committee, was called the SNOT trial. I forget what the acronym SNOT stood for, but anyway, the SNOT trial has obviously been very successful. So I'm now going to hand over to the first moderator for the afternoon, Dr. Ishrat Husain.
Thanks, Robin, and welcome everybody to the afternoon sessions. I'm Ishrat Husain. I'm a psychiatrist and associate professor at the University of Toronto, and I'm a member of the grants committee at the PSI Foundation. And I'm really pleased to present our next speaker, who is a PSI trainee presenter and one of our awardees for our resident research grants. And one of the most satisfying pieces of work that we do with the grants committee is actually supporting the next generation of clinician scientists. So I'm pleased to present Dr. Brett Jones. Dr. Jones is a psychiatrist and research fellow in mood disorders and psychedelic science at the Centre for Addiction and Mental Health in Toronto. He completed his degree at St. George's University and a master's degree in residency at the University of Toronto. His research focuses on evaluating novel interventions for mood disorders, and in 2021 he was funded by PSI in the depths of the pandemic to lead a very interesting feasibility trial of a digital psychological intervention, dialectical behavioural therapy, for people admitted to CAMH with acute suicidality. So it was a very timely study, and that's what he's going to speak to us about this afternoon. So everybody, welcome Dr. Jones.
Thanks very much for the introduction. I think that's the first time I've heard myself presented like that, so it was very nice. I appreciate it. So as Dr. Husain mentioned, I'm going to present on a resident pilot grant that was very graciously funded that we finished this past spring. And so we're kind of putting together some of the results, and we're going to be submitting for publication, hopefully in another very high-impact journal as well. I have no disclosures related to this talk. Just to walk you through what I'm going to cover. So first I'm going to cover a little bit about the background, the rationale, why we applied for this project, our methods, very briefly about some of the results, and then future directions. So suicidality. So we, as psychiatrists, this is a very common presentation that we work with. Suicidality, what it refers to is it's a spectrum of suicidal thoughts and behaviors. So not wanting to be alive or thinking life is not worth living. And it really is a spectrum. You can go from no thoughts at all towards intrusive thoughts to thoughts about maybe a plan, how you may do it, but you don't really think you'll do it, to actual intent to do it, and to actually, I will do it tomorrow, for example, and then attempts. So it's a full spectrum that we work with, but it is truly one of our biggest sort of psychiatric emergencies. So I'm an inpatient psychiatrist, so a lot of my practice is on the ward, and so it's a very common indication for why people are admitted to hospital, particularly when there's concern about safety. When these people do get admitted to the hospital, how do we treat this? How are we treating the suicidality? So it's really, to boil it down, it's two components. There's containment of risk, so effectively we're just keeping them safe. So that's a major part of the treatment. But then sort of medically, we're trying to treat the associated disorder. So if someone has major depressive disorder and they're suicidal, we treat the depression and we hope the suicidality gets better. If someone has schizophrenia with suicidality, we treat the schizophrenia and hope that the suicidality gets better. But there has been sort of more emerging and exciting evidence to suggest that actually targeting suicidality specifically is more effective at reducing suicidal thoughts, which I think makes sense intuitively, since suicidality occurs across almost all disorders. So it does make sense that sort of it could be treated sort of as its own entity as well. So some of those treatments that kind of have suicidal specific effects. So Some of the older treatments, like medications like clozapine or lithium, have known anti-suicidal properties. Brain stimulation such as ECT has been shown to be quite effective at reducing suicidality, and psychotherapies such as dialectical behavioral therapy also has been really effective. What are the gaps for the inpatient? So some of the issues are a lot of these treatments, some of the ones I identified, are they actually feasible in an inpatient unit? The inpatient units are very complex. We have voluntary patients, involuntary patients, people come and go. Like, how practical is it actually to start and finish a treatment? Also, a lot of the treatments that we mentioned aren't available. So if you're in a rural setting, you might not be able to get ECT. Even in downtown academic hospitals in Toronto, psychotherapy is scarce. It really, truly is just group therapy that's sort of meant for everyone. There's not really very specific therapies. And then also, does the evidence translate to this severe population? So this is some of our most severe patients. And most of the studies of effectiveness would have excluded all of these patients because they're highly suicidal. And so really the question is, will these treatments actually work for this spectrum? The analogy I tried to think of like a general physical health medicine analogy, would be trying to treat ICU delirium based solely on evidence from long-term care facilities. Similar presentations, but vastly different in severity. So this led to the application that, again, very graciously were supported, really with the aim to determine if a digital DBT skills intervention would be a feasible and acceptable treatment for these patients admitted with suicidality on an inpatient unit, and then secondarily to try to see if this would be an effective treatment. So what we were trying to do is to bridge this gap to really evaluate, can we integrate a treatment to target suicidality specifically, and then the gap of lack of psychotherapy resources by trying to harness digital psychotherapy, which there's a lot of, but very limited evidence to whether or not they actually work. So what we developed and implemented was a randomized controlled trial versus digital DBT versus treatment as usual. The flow basically went like patients would be admitted, they'd be identified by the psychiatrist as potentially suitable for the study. We would screen them. If they were eligible and wanted to enroll, we'd enroll them. Then we did questionnaires around psychological distress, emotion regulation, suicidality. We then gave them the intervention, which I'll go over in the next slide, but it's a 5-module intervention. We gave them a few days, 5 to 10 days to complete it. We then redid the questionnaires after the intervention at discharge, and then a 4-week follow-up. We really wanted this to be holistic because the patients that come up onto the unit, really, it's not just one type of patient. So really the exclusion criteria, you had to be 18, you had to be admitted for suicidality. We asked that you would likely be there for 5 days. Suitable for psychotherapy, meaning you had to be sort of able to do psychotherapy. Some patients are really agitated, really elevated, so those people wouldn't be suitable, and no brain stimulation because of cognitive effects. So the modules, as I said, was 5 modules. It was an internet-based application, so you would go on a website, you would click onto the link. Each module is about 45 minutes. They covered 3 of the 4 key components of DBT: mindfulness skills, emotion regulation skills, distress tolerance skills. And then you would work through homework review, you would learn a new skill, you would then apply the new skill, and then you'd be assigned homework for the next day. And I should say that we adapted this app, but this was an app that was evaluated in an outpatient population in the United States, and so one of the collaborators gave us the application to work with. So we assessed 61 people for eligibility. Some of them were excluded, mostly because I think a lot of the psychiatrists referred people who were going to be doing ECT, so that's why that number is reasonably high, despite the not many exclusion criteria. And then 7 people didn't want to participate. We reached our target of 20 per arm. 15 completed the intervention, and 18 completed the control group, which was just treatment as usual. To give you a sense of the population, so average age 35, pretty even split, gender. The diagnoses covered pretty much every possible diagnosis. Anyone familiar with psychiatric research often excludes substance use disorders. About half of our patients had that. For me, I think it's important to emphasize that the number of diagnoses was on average 5. So this is a highly comorbid patient population, not your typical clinical trial population for psychiatry. The main aim was feasibility. I think actually we showed that it was feasible to do the study. I'm just going to highlight a couple of the exploratory aims. From baseline to end of the intervention period alone, so that 5 to 10 day window, the patients who received the digital DBT skills had a quicker, significant reduction in suicidality compared to the control group, though both had a reduction in suicidality. And then a similar pattern for emotion regulation as well. So it was just showing that those who sort of took the DBT intervention and enrolled were able to have a more quick reduction in symptomatology. We have data for the longer term and the 4-week follow-up, but I'm just in the process of analyzing that, so I can't really speak to that. One important thing to consider for digital interventions are they safe? There was actually a large study in the States, one of the, I forget what they're called, like the health groups, just gave everyone who had a psychiatric complaint a digital psychotherapy app. And interestingly, they reported the people who got the app did worse than the people who didn't get the app. So I think that emphasizes the importance that even though it's not a medication, but there still needs to be concern around safety and tolerability. So we had no issues in our 40 people for adverse events. Non-completers were mostly, some people said it felt too much like school. Some people didn't want to take part in the study after they were assigned to the control arm. Some people were actually discharged within that 5-day window, despite us trying to not recruit people that would be discharged early. So that was one of the challenges. So conclusions and next steps. So clinical trials and applications of digital DBT interventions seemed to be feasible. It was well accepted by staff. It was generally accepted by patients. It may be effective, though we need to sort of replicate this. And sort of the future direction. So what we're very excited is to take this sort of pilot data, apply for larger applications, studies. So a replication of this study. We're also putting together applications for how to integrate this into the outpatient clinic as well. And then also see if we could integrate biological information into this, so actigraphy, like measures of like sympathetic heart rate and that sort of thing. So I just wanted to thank everyone for listening. Thank you for inviting me to present this. I was very excited to present this. This was the first grant that I ever was awarded. So for me, this was it was amazing. So I'm very appreciative to the foundation for awarding this. It sort of has, I feel like it's sort of dominoed a lot of success afterwards. So it's been great. And the co-investigators and obviously my mentor as well. So,
Yes, it is. Any questions for anybody? Deborah?
So much enhancing tolerance to distress, or the emotion, like how the digital device interacts with the patient, like to do what to what end regarding the distress tolerance.
Yeah.
I'm sorry, I wasn't familiar with that phrase. And then the emotional dysregulation, like tips to help yourself with your own emotional dysregulation. Is that what?
Yeah, so one of them is called TIPS as well. So it's basically DBT is a modular psychotherapy. It's a third wave psychotherapy. It's manualized, and so there's skills that you're learning. So it's effectively, if you're feeling overwhelmed, this is something you can do. Because I think what happens a lot of times when people feel like a stressor comes, they feel quite overwhelmed. Yeah. Then their reaction will be to, well, then I might as well kill myself. And that's the sort of behavioral reaction to the emotional sort of reaction, where this is skills and tips to sort of change that sort of behavior to, well, why don't I go for like a run? Why don't I exercise? That sort of thing. There's 4 key components to DBT. So skills based in mindfulness, so being present, aware, those sort of things. Distress tolerance skills, so learning to handle distress. Sort of being okay with it, like radical acceptance, be like, I'm upset right now, but it's okay to be upset because my boss just yelled at me. And then the emotion regulation, which I talked about. And then the third one, which is not in this module, is interpersonal effectiveness. So like how to communicate with people in ways that can be more productive. Because I think a lot of the folks that struggle with emotion regulation, they come off as meaning like the way they're not trying to come off as, which then leads to conflicts and then leads to spiraling. It was quite didactic, and so it basically was, it followed a similar structure where you reviewed, what you learned yesterday, because repetition is important. Then a new concept was introduced, which was based from a video, which the videos were actually from the developer of the therapy, which was quite neat. That was about 15 minutes, the video, and that was teaching of the concept. And then it was slides that would sort of reinforce the concept, show how it can be applied in areas of your life. Like anyone at U of T, when you have to do every year we do our security modules, it's like basically that, like you're clicking through something. So it's those sort of online modules.
Thanks for a great presentation and congratulations on your award. One of the interesting things about psychosocial interventions in a contained setting, like inpatient, is that possibility of quote unquote contamination, but in a good way, or not, of clinicians who are in the looking after the quote unquote treatment as usual group. And I'm wondering if you have any sense of potential effect on the staff in the milieu either. And at first I thought, everyone might pick up more, is everyone going to become more DBT informed? But then on the other hand, I wonder also, could it go the other way where staff may become less clinically interactive if there's a sense? Do you have a sense of how would you go about potentially looking at effect on the other?
So a couple things we tried to do. We had the research assistant check in with the people every day to see if they had any problems with the app. We also had them also check in with the control group just to be like, is there any concerns? But it was kind of superficial because there wasn't really much, because the check-in is important too. Yeah. I think from the spirit of DBT and most psychotherapies is that you're not really supposed to learn at once. It's like any skill. It would be great if the unit became more DBT aware, but then the treatment group would also be getting that sort of same benefit because they're getting the same treatment as usual. And I would say even on the unit, there are DBT skills group. Even people in the treatment as usual could have theoretically gotten some degree of DBT skills, but not a comprehensive.
I will add though that this was done during the pandemic when actually there was very limited interventions in terms of group therapies on the units. And it was one of the sort of ideas that we had that we wanted to do something like this because they were getting nothing really much other than psychiatric check-ins. There is some obviously psychotherapy, but not structured.
And it's not meant to replace, I think, in group person therapy. It's to be like a supplement. Like, what else can we add? Because oftentimes they're just sitting, like these folks sit around and there's a boredom. So we're kind of like, let's.
Hi. Great project. So the context is that I'm a general internist and I see a lot of patients, especially in the last 2 years, in the emergency for suicidal attempts that I'm seeing for their drug overdose or withdrawal symptoms. And so I'm following them. And then this question comes up of whether they should be admitted for their suicidal attempt, and our psychiatry colleagues help us with that. And so this struck me as a very interesting project that it was done in the inpatient setting, because even just getting admitted, I think, is a minority of patients that come in, at least in this context with this patient population. So I was curious as to, was there a reason why it was done in the inpatient, your intervention was used in the inpatient setting, other than because of safety concerns? And the second question was there any measurements that looked at perhaps length of stay, knowing that this might actually help length of stay if people felt that safety was the reason why they needed the intervention?
Yeah, so length of stay is an exploratory. We do have that variable, so we'll look at it. I haven't yet. I think there was a pragmatic, where we both work on the inpatient unit, so it was a project that we could sort of implement. So there was that aspect. It was pragmatic to do. But I think what you're describing too, it is, because our hospital is a psychiatric-only hospital, and I think a lot of people do present to our hospital with suicidality, and they get discharged. They get referred to like crisis clinics, urgent follow-up, and this sort of intervention could actually be helpful for them. I think the target population, though, was kind of the ones who do get admitted, and theoretically they would be the more severe. And I think what spawned this question is, as Dr. Husain had sort of alluded to, like we check in with these patients every day, and we know what they kind of need, and they're not getting it. And so we were trying to see about how could we bridge the gap of care, because they're just not getting they may get a couple of the skills, but they're not getting sort of something more comprehensive.
And also this population is traditionally
But there are studies, sort of like check-in studies. So after you've been discharged from the emergency room, a phone call, just to be like, hey, like, how are things going? So there is that area of research, though, for the folks that you're seeing that aren't getting admitted.
Great project for a fellow to do a randomized control trial, amazing. As an extension to it, do you feel that, for example, if after going through these modules and sometimes when they get like decompensated, do you feel that having a virtual person or like maybe AI person in the future, at least like, talk to, it will be the next step, and some kind of an online consultation with some mental health professional, either be it a psychologist, like a nurse, anybody, and then that can be escalated further, is one way of keeping these complex patients like safe in their environment.
Yeah, 100%. I think some of the research would suggest that clinician-guided electronic therapy is superior. Someone to check in if you need to be checked in with, that would be the logical next step for any, if we were to say, put this for a larger project grant, which we will, I think we would probably include something like that.
Thanks so much for your presentation. That was really, really helpful and exciting to hear about. I'm finding myself thinking a bit about Nav's presentation earlier today and recognizing the challenge of working with a patient population that's struggling with mental health. But I was also really struck by the comment from patients that it felt a bit too much like school, perhaps. And I wonder about the opportunity for that kind of guidance panel when we're developing tools. And I apologize if you spoke to it and I missed it, but I wonder if that's something that might be considered to be built in for future opportunities.
So I did, thank you for bringing that up. I didn't say it aloud, but it was on my slide. So for the future, we patient engagement to really try to make this a better application. Yeah.
So again, I mentioned it here because this project has spawned a lot of different like sort of projects in various